עמיתיי, חברים שלי. אני רוצה לומר קודם שאני כל כך שמח לחיות פה היום בבית חולים רמבם. ועכשיו באנגלית, בבקשה. So I'm going to talk today. Now before I do that, I want to thank the organizers of the meeting, Dr. Balbir and her colleagues, for allowing us to have this meeting here today and to integrating it into the current International Rheumatology Conference in Israel, which is taking part in this hospital today. I'd also like to thank Yael for all the organizational help she's given towards this symposium and for help in translating my slides. So I'm going to talk about Ehlers-Danlos syndrome. As you've heard very eloquently from Yael, we now believe, or most of us believe, perhaps not everybody, that Ehlers-Danlos type 3, as it used to be called, or the hypermobility type as it is now called, and hypermobility syndrome are one and the same. But when we come to think about what it's causing it, we have to go to think about collagen. Collagen is a very tough protein. It's a very important protein because it gives the body all the strength it needs, and therefore it's not surprising that you find collagen in many, many parts of the body, many important organs of the body. It happens to be also the most widely distributed protein in the human body. And because of its strength, it is a major component of tendon, ligament, skin, and other parts of the body like the whites of the eyes, the sclera, and the heart valves are all made of collagen, and many other organs as well. Because skin is 70% collagen if you remove the water, it's also a very important area for assessing the collagen of the patient, or the person concerned. And collagen also forms an important part of the infrastructure of bone, cartilage, and muscle as well. So you don't have to look very far for collagen, and it's not surprising when collagen goes wrong that it has effects which affect many parts of the body. I've got a little diagram up here which shows you how we view the present situation. We all know that hypermobility, Ehlers-Danlos, runs in families, and if you draw out the pattern of inheritance by questioning and examining members of the same family, you realize that it is an inherited disorder. And in fact, it follows the pattern of dominant inheritance, so that it goes from one generation to the next. Now, genes, I don't mean the ones you wear, I mean the ones that we're talking about today. Think of genes as a direction, an instruction to the body on how to produce proteins. So if there is a genetic abnormality, a mutation or some other abnormality, it can affect the ultimate structure and function of the tissue concerned. In our case, we're talking about collagen and other similar proteins, and a genetic anomaly here will give rise to a change in the biochemical structure, the chemistry of the protein collagen, and that itself can affect how the collagen functions, and it may impair the function. collagen so that it's less tough, less protective, and this can give rise to problems. It seems that there are two results of this process. Firstly, it can result in tissue laxity. In other words, that the ligaments, for example, are more stretchy, they are more malleable. And that means that, for instance, in the case of the joint, that the movement is enhanced, is increased. And that is, you might call the good side of hypermobility, because it allows more flexibility, more movement, and this is an advantage in many areas of activity. For instance, from my experience, I would say that most dancers, most ballet dancers, but in fact other dancers too, you will find are hypermobile, and it's not necessarily that this was the result of their activity, but the cause of their activity. They were allowed to become dancers because of what they could do. Hypermobility gives you the ability to move more than other people can move, and therefore you can do things that other people can't do. But that's the positive side. The downside is that it's less tough. It's less robust. Collagen's main virtue is that it's normally very tough and protects the body and allows you to do things that involve strength and heavy physical activity. And if the tensile strength of the collagen is reduced, then things break easily, more easily. Things don't take kindly to very strenuous activities. And you'll learn later when you see the film. So there are these two opposing factors here, which one has to bear in mind. But there's a third issue here, because fragility may lead to injury. There's what happens after injury. Injury heals. How does injury heal? It heals by the laying down of scar tissue. What is scar tissue made of? Collagen. So that healing is impaired, and as you've seen from some of the photographs that Yael showed you, scar tissue may be not high quality scar tissue, and this can have effects as well. I've talked about, well, I haven't talked about, mentioned skin, and there's no doubt that in Ehlers-Danlos syndrome and many other inherited disorders of connective tissue, the skin is stretchy, and that's a very valuable clinical sign, but it's amazing how often it's not tested in the clinical situation. Now, I'm showing two examples here. On the right, you see skin that is very stretchy, and I think this would probably represent a fairly typical example of what Yael has referred to as the classic form of Ehlers-Danlos. And this is what doctors learn about, and they think that if it's not like this, it's not Ehlers-Danlos. But in fact, if you look at patients who've got the hypermobility type, it's more like this. And it should not be dismissed, although it often is. It's a much more subtle process, because the skin elasticity is not so immense. Now, I started an interest in the skin in Ehlers-Danlos way back in 1970, and this was me testing skin, and for the first time measuring how skin stretches in the intact human body, comparing patients with Ehlers-Danlos with control subjects. And what was found is shown on the next slide, that this is what we call a stress-strain curve, so that the more pull you make, this is against the degree of stretch. And you'll see on the left is the control subject, on the right the Ehlers-Danlos syndrome patient, and you can see that there is a difference, and the difference is in the early part of stretch, which we often refer to as the giving up of slack, taking up of slack part of stretch. And this is represented in the clinical sense by the fact that when you raise the fold of skin, either in this plane or in this plane, you don't just see stretch where you applying your traction, but you see the process takes place right the way up to the wrist and all the way around the hand. And, this may be explained by the fact that the skin in Ehlers-Danlos syndrome is different from the skin in the normal subject. It's thinner, it's more spongy, and you don't see the fully developed bundles of collagen that you do in the normal subject. So, and that's why it breaks more easily, because it's not so tough, because the collagen is not developed to the same degree. I often use what I call the rubber glove sign, and whether we'll actually get a some action here will depend on whether on the age of the computer. Let's just see if I can do it. No activity. We'll pass on. It merely shows in real time what happens when you stretch the skin, but I've always showed it to you already on the photographs. Now, one of the remarkable things about this syndrome, looking at it historically, is how much our knowledge has increased over the last 40 years. In 1967, it was first described as the hypermobility syndrome, and it was defined as the occurrence of joint of pain and instability in patients who had generalized hypermobility, but, and this is the but, the important part, in otherwise healthy subjects. And this was the definition that was adopted in 1967. And this, unfortunately, turns out to be incorrect. And it's had a major impact on the recognition and on the consideration of the syndrome. Because, sadly, many of our colleagues still accept that as the situation. Against this background is what's been happening over the last 40 years. And as you can see, a lot's been happening over the last 40 years. And you can see the timeline here from 1967, when it was easy and it was simply joint pain and instability, that a lot of evidence has come forth, a lot of new aspects which we never dreamt about have presented themselves, and the result is that we now have quite a complex situation. The first clue was that there were features on examination, skin stretch, marfanoid features, that overlapped with the major diseases of the heritable disorders of connective tissue. That's Marfan syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta. But that was just the beginning of a clue, a kind of dawn of knowledge. And then as time went by, the evidence accrued of other problems that were found in people who had hypermobility. The first was the pelvic floor and the impact of the pelvic floor on in EDS and hypermobility, uterine prolapse after childbirth in particular. I won't go into the details. And we now know that that is actually a very important area and a cause of much unpleasant symptoms in many people. The next thing, if we come into the 1980s, was the impressive work from Barcelona, from Professor Bolbena's department, that certain psychiatric disorders, not all by any means, just anxiety and phobias, particularly manifesting as panic attacks and social phobias, claustrophobia, were common in these patients. Now, the more I see patients, and I see a lot of patients with this condition, the more, and it's children as well as adults, suffer greatly from these problems. Then the 1990s, this is a kind of crescendo that's developing here over time. Chronic pain, not just joint pain, not just ligament pain or muscle pain, as you would get with muscle injury and ligament injury. This is a different kind of ball game altogether. Chronic pain is very different. It doesn't follow the anatomical rules. It doesn't relate specifically to injury. It doesn't respond very well to pain-killing tablets, analgesics, and it is very difficult to treat. But it was only in the 1990s that this became apparent that it was a very important, in many patients, the most important aspect of the condition. Then, in 2000, dysautonomia. I won't dwell on this one because I know that Professor Jacob is due to speak on this subject very shortly. I will refer to his work in a moment, but let's go on in time to the onset of the new century, that we first realize, or it's drawn to our attention, that the bowel is another target for this condition. And it affects the movement of the bowel. We call it the motility of the bowel. And when the motility of the bowel is affected, we use the term dysmotility, when it's not working properly. And because the bowel is an important, very important organ, but it also has a lot of collagen in it. And if the collagen is impaired, it can't function properly. And about the year 2000, it struck me that many of our patients were actually quite severely disabled. And we know this by the fact that patients started to arrive at our clinic in wheelchairs, and as a rheumatologist, starting out in the 60s, when we used to see lots of patients arriving at our clinics with wheelchairs, that's all disappeared in rheumatoid arthritis. And now we were seeing more patients disabled by their condition. And it's now looking a fairly menacing selection of different complications. But that's not the end of it, because we haven't got to the end. We're only at 2010. Unfortunately, the triangle was full, so we had to start another one. I wanted to just drop off at this point to mention and pay tribute to my colleagues who are here, who published this important landmark paper in 2003 from this hospital. I was very privileged to be invited to join them on this paper. It was the first paper that really clinched the fact that autonomic function was impaired in patients. And it was published in the most prestigious medical journal there is, the American Journal of Medicine, and it's been quoted and quoted and quoted ever since. Let's go back to leave that. Let's go back here. This is my new triangle, additional triangle, to bring us up to date. We now know that there are problems within the central nervous system that we didn't know about before. The association here with what's called Chiari-1 malformation is when the brain seems to sink a little bit into the top of the canal of the cervical cord. The fact that there may be instability between the skull and the top of the cervical spine, the neck, leading to pressure on nerves, which can be very important. Tethered cord syndrome is another part of the triad, and we're only just beginning to get to grips to understand what's going on here. And then finally, and I won't say very much about this, mast cell activation. This is the cell that produces histamine, that is the mediator for allergy and allergic responses. And we're seeing more and more patients now who seem to have this on top of everything else. So we've got now a very complex, multi-system disorder. And we have to think about how we're going to pick these patients up, to recognize them, to diagnose them, and then to treat them. Because all these different aspects may require treatment in its own right. Now, about 15 years ago, we did an estimate of the number of patients that were being diagnosed and not being diagnosed, because we know that this is a condition that is often not diagnosed until late. So I won't go into how we came about this conclusion, but this is the stark conclusion. It was based on the statistics of the number of patients who attended rheumatology clinics and the number of patients who had features of hypermobility and EDS. And we also took into consideration the number of patients that the rheumatologists thought they saw, and their own estimates. And we found that out of every 20 patients who saw a rheumatologist in England, and it relates to England, not Scotland or Wales or Northern Ireland, in England, that there were 19 who were not diagnosed. And this is a very, at the time it was a very alarming statistic. Another revelation was the fact this was a survey conducted under auspices of the Hypermobility Syndrome Association in the UK. A simple question: how long did it take you to get diagnosed? And 52% of the 138 patients waited more than 10 years for a correct diagnosis. Now this is wrong. This is unacceptable. But it's true. Now, one of the things that we have very little knowledge about is how frequent, how prevalent hypermobility syndrome or Ehlers-Danlos syndrome is. And up till very recently, there were no statistics. There were no epidemiological studies that could answer that question. And this study that was published in 2013 is about the only relevant piece of epidemiology we have. But it did look at a large number of people from a population, 4,000. And they had two facets. They weren't diagnosed with EDS because the people who did the survey didn't know how to diagnose EDS, but they just recorded two aspects of their symptomatology. One is the fact that they did have widespread chronic pain, and these authors knew about widespread chronic pain because that's what they studied, but they incorporated into their study, thankfully, a score for hypermobility. In other words, they used what we call the 5-point questionnaire, which gives an accurate, because it's a validated questionnaire, an accurate estimate of the prevalence of hypermobility in the population. So they just took these two things, 16, and they found that 16% had widespread chronic pain, 18% were hypermobile. And they then looked at the proportion, in fact they didn't, we had to prod them to do this, who were both had widespread pain and hypermobility, and that turned out to be about 3% of the population. Now 3% of the population is very, very common. Especially as if you look at the textbooks, it says that it's 1 in 5,000 for EDS, and that's not based on any data at all. So it clearly is, and this is not using the diagnostic criteria that we would normally use, it's a guesstimate based on a proxy, which means it's the nearest we can get to anything realistic. Now, I want to review the situation of hypermobility and EDS in the concept of the medical profession. We know now it's high prevalence, it runs in families, it's easily recognized. If you look for it, if you know how to look for it, you find it. You don't need, it's not rocket science, it's if you follow and you know what you're looking for, and you find it. The problem is, of course, that people don't do that.
Escape.
Stop. Okay, sorry. And it infects children, it infects adolescents, and it affects adults, and it affects older people too. I'm pressing backwards, that's what it is. And it doesn't cost a lot to diagnose it. You don't need any expensive imaging in most cases. There is no genetic test for this condition. Whatever you're told or whatever you think, there is no genetic test yet available for this form of EDS. And we know that there are principles of management based on experience of how to manage the patients. Yet it remains a major cause of preventable disability and psychological distress, as I've mentioned, and it's not just an Israeli problem or a British problem, it's a worldwide problem. I'm having problems here. No, that's not good. Okay, it's good now. Okay. Therapists are often... No, it's not. Why would that... You can take them all the way down, yes. Don't knock them back. Okay. Medical students aren't taught about it. Specialists in training aren't taught about it. Teachers of medical students don't teach it. They don't have the knowledge or the experience. And as I said before, many rheumatologists, if not most, still follow the concept that were present in the 1970s. Now I'm going to press again. Okay. So one of our colleagues, Isabel Knight, wrote a book which was very for patients. Many of you may have seen it. It talks about the treatment and about the nature of Ehlers-Danlos type 3. She asked me if I would write a foreword